Welcome everyone to this explainer on Decode Healthcare. I'm your host Harshal, and today we are decoding the complex and sometimes honestly a bit confusing inpatient journey of our very youngest patients. We're tackling a highly specialized, absolutely crucial section of the CPT manual, newborn care, right alongside pediatric and neonatal critical and intensive care services. If you've worked with these codes, 99460 through 99480, you know they are notorious for their incredibly strict rules based on age, weight, and acuity. So let's just jump right in and break it all down.
Okay, really quickly, here is our agenda for today. We'll be moving through normal newborn care, delivery room and resuscitation, pediatric and neonatal critical care. Then we'll look at intensive care and those tricky weight rules. And finally, we'll wrap up with bundles and care transitions. All right, Section 1. We're starting with normal newborn care, which covers codes 99460 through 99463.
So, for these healthy babies, your code selection hinges purely on the location of that initial day of care. It's actually pretty straightforward. Code 99460 is used for initial hospital or birthing center care. But let's say that exact same healthy newborn is evaluated in a totally different setting, like a clinic right after birth. In that case, you're going to use code 99461. The patient is the same, the acuity is exactly the same, but the place of service completely dictates your code.
Now, what about the days following birth? Well, we rely on subsequent and same-day codes. Code 99462 is your go-to for every subsequent day a healthy newborn remains in the hospital. However, if a newborn is admitted and discharged on the exact same calendar date, you just bypass those other codes entirely and report 99463. Nice and simple, right? But here is an absolutely crucial CPT instruction you've got to remember. Normal newborn services are limited strictly to those first days after birth, prior to home discharge. Once that baby goes home, that's it. You no longer use these 99460 series codes for their follow-up care. Instead, you're going to transition over to standard office, outpatient E&M, or preventative medicine codes.
Moving on to Section 2, Delivery Room Services, specifically focusing on standby versus resuscitation. In the delivery room, you must clearly distinguish between a physician who is just on standby versus one performing active, life-saving measures. Code 99464 is for requested attendance and initial stabilization. But if things take a turn and the baby is in distress requiring active resuscitation, and by that CPT specifically means positive pressure ventilation or chest compressions, you immediately escalate to code 99465. And remember, you cannot report these two together. You have to pick the single code that matches the intensity of the intervention.
Now, here is a massive coding tip for you. While you definitely use 99465 for the resuscitation itself, you can still separately report necessary procedures like endotracheal intubation if it's done before NICU admission. So if a physician performs an intubation, that's code 31500, or inserts a vascular line as part of the resuscitation effort, you absolutely want to bill those in addition to 99465.
All right, Section 3. Let's escalate the acuity and talk about critical care for pediatric and neonatal patients.
Now listen, this is a massive rule of thumb to commit to memory. Unlike adult critical care, which is totally time-based, these neonatal and pediatric codes are a daily global package. Adult critical care requires you to obsessively count minutes. But for neonates and pediatric patients, CPT groups everything into a per-day global service. Whether the physician spends 2 hours or 12 grueling hours managing that critically ill child, it is all reported with one single code per calendar day. So, if it's not based on time, what is it based on? Age brackets. Memorize these brackets. 99468 and 99469 are strictly for neonates 28 days of age or younger. Literally, the moment that baby hits 29 days old, all the way up through 24 months, you shift gears to the pediatric codes 99471 and 99472. Then, for children aged 2 through 5 years, we use 99475 and 9946. And what happens when they turn 6? Well, they age out of this structure completely, and you just revert right back to the standard time-based critical care codes.
Looking at the guidelines, you can see the CPT manual strictly delineates these age brackets, starting specifically from the date of admission. These codes represent care starting with the date of admission for critical care services, and all subsequent days the patient remains in critical care. It's a very tightly controlled section of the manual, for sure.
Okay, Section 4, Intensive Care and Weight-Based Rules. Let's step down our patient's acuity just a little bit.
For the initial intensive care of a neonate, 28 days or younger, we use code 99477.
This is for intensive observation and monitoring of a baby that doesn't quite meet the strict definition of critically ill. But for every single day after that initial day, a completely different variable takes over. It's no longer just about age, it's all about the baby's present body weight.
You literally have to check the medical record for the current day's weight in grams. If the recovering infant's present body weight is less than 1,500 grams, you report 99478. If they are between 1,500 and 2,500 grams, it's 99479, and over 2,500 grams, you report 99480. Because a baby's weight constantly fluctuates in the NICU, the code you report can actually change from day to day as they cross these specific weight thresholds. And just to reinforce this, much like the critical care codes we discussed a minute ago, these intensive care codes are also global, per-day services. They just happen to be based on weight. They encompass the entire calendar day's worth of intensive observation and management by the physician.
Finally, Section 5. We need to talk about bundles and care transitions.
Because these daily codes pay a much higher global rate, CPT has already bundled a ton of invasive procedures into them. When you report a daily, critical, or intensive care code, you're essentially telling the payer, hey, we are providing a comprehensive, all-inclusive package of life-supporting care today.
So please do not let your billing system trigger an automatic denial by trying to unbundle these services. Endotracheal intubation, umbilical catheters, CPAP, and surfactant administration are all strictly bundled. If you perform any of these on the exact same day you bill the daily global critical or intensive care code, you cannot bill them separately. They are considered fully baked into the intensive work represented by the E&M code itself.
Now, let's look at the natural progression of a healing neonate. They usually start with critical care codes based on their age. As their acuity improves and they stabilize, they step down to those intensive care codes based on their weight. Finally, when they just need standard hospital observation before discharge, they transition to regular subsequent hospital care codes, which are 99231 through 99233.
But what happens if a patient transitions between these units on the same calendar day? Well, the guidelines are crystal clear. You cannot double dip. Say it's a Tuesday, and your tiny patient improves enough to drop from critical care down to intensive care. The transferring physician does not get to bill both codes for that day. You bill based on the condition of the neonate, and only the receiving individual reports the appropriate subsequent intensive care code. So, I'll leave you with this. How will you apply these strict age, weight, and acuity rules to your next complex NICU coding case to avoid costly denials? I really hope this explainer helps you master this challenging section. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.